Welcome to The Explainer. Today, we're going to step into the shoes of a clinical detective. Our mission? To solve a series of fascinating medical mysteries. So think about it. A patient has a tremor. Another has a rash. Where do you even begin? Well, today, we're going to explore the art of diagnosis. We'll see how clinicians sift through a whole world of possibilities to find that one single correct answer, often using clues that are hiding in plain sight.
All right, let's kick things off with cases where the solution, believe it or not, is found just by carefully observing and really listening to the patient's story. Okay, case file number 1, the shaky hands. We've got a patient with a tremor. It's progressive, it's symmetrical, meaning it's in both hands, and here's the key part. It gets way worse when they try to do something, like signing their name or just trying to take a sip of coffee.
And this is where things get really interesting. The key isn't just that there's a tremor, it's when it shows up. See, a tremor that's worse when you're just sitting still, that's classic for Parkinson's disease. But a tremor that gets worse with action, just like our patient, well, that's the telltale sign of something completely different.
So you put the pieces together, an action-based tremor plus, often, a family history of the same thing. And boom, that points straight to a central tremor. The mystery is solved, the diagnosis is clear, and you can start treatment with meds like propranolol. All right, on to our next case, the unrelenting itch. Picture this, a patient with end-stage kidney disease. They have this maddening, all-over itch. But, and this is the real head-scratcher, there is absolutely no rash, nothing to see. So what's going on?
This is a fantastic example of what's called a diagnosis of exclusion. The detective work here is ruling things out. Is it scabies? Nope. Dry skin? Nah. Fungal infection? Not that either. Drug reaction? No. Once you've crossed all the usual suspects off the list, you're left with the smoking gun, the patient's kidney disease. And that gives you the answer. Uremic pruritus. It's an itch caused by the kidney failure itself.
All right, things are about to get a little tougher. We're moving on to cases that are all about unmasking the mimics, conditions that look so much alike they're like medical twins.
So here's the scenario. A patient develops rapid weakness in both legs. Is it transverse myelitis or is it Guillain-Barré syndrome, GBS? It's a real diagnostic showdown because these two are serious and they can look nearly identical at the start. So how on earth do you tell them apart?
And the answer, brilliantly, is in the physical exam. It's all about the reflexes. You see, transverse myelitis is a problem in the spinal cord, and that causes overactive reflexes, or hyperreflexia. But GBS, that hits the peripheral nerves, out in the limbs, and it causes the reflexes to be completely absent. Areflexia. It's a night and day difference that tells you exactly which path you're on.
Okay, our next case file deals with something pretty common, but it can have 3 very different culprits. The key is that each one leaves behind its own unique fingerprint for a sharp-eyed clinician to find. And this is basically the detective's cheat sheet. It's all about the specific features. Those are your clues. For instance, if it's thin, gray, and has a fishy odor, that's shouting bacterial vaginosis. If it's thick, white, kind of like cottage cheese, you're looking at a yeast infection. And if it's frothy and yellow-green, and the doctor sees what's called a strawberry cervix during the exam, that's a classic sign of trichomonas. The clues are right there.
Okay, let's raise the stakes. We're moving into the really critical calls now. The situations where spotting one single subtle sign, a red flag, can literally change everything for a patient. So, imagine this. A patient walks in with a firm lump in their salivary gland, right there in front of their ear. It doesn't hurt. You might think, okay, maybe it's nothing. But there's one other sign, an alarming sign that changes the entire story. And here it is. This is the big one. The saying goes, facial nerve palsy with a parotid mass is malignant until proven otherwise. What does that mean? It means if the patient can't smile on that side of their face, the nerve running through that gland is in trouble. And that one sign instantly flips the switch from maybe it's a benign growth to we need to suspect cancer and act now. And when that happens, the plan of attack has to follow a very specific order. You see the red flag, so step 1 is to suspect malignancy. Step 2, you image first. Get a CT or MRI to see exactly how far it's spread. And only then, as step 3, do you do the biopsy. Why that order? Because it gives the surgeons a complete map of the battlefield before they even think about making an incision.
Okay, next up, a classic, shingles. You get this painful, blistering rash, usually in a very distinct line or band on just one side of the body.
Diagnosing it isn't usually the hard part. The challenge here? It's a race against the clock.
72 hours. That number is everything. You absolutely have to start antiviral treatment for shingles within 72 hours of that rash showing up. Why? Because if you do, you can dramatically lower the risk of this awful, long-term nerve pain called post-herpetic neuralgia. Miss that 72-hour window, and the chance to prevent that debilitating pain is pretty much gone.
All right, here's a really high-stakes scenario. A pregnant woman, 34 weeks along. She just got off a long flight, and suddenly she can't breathe. This is the absolute textbook setup for a pulmonary embolism, a life-threatening blood clot in the lungs.
But here's the twist. Making the diagnosis is complicated because she's pregnant. You have to think about radiation. The two main tests are a CT scan or a VQ scan. As you can see, the CT scan, or CTPA, gives a much higher dose of radiation to the mother's breast tissue. That's why, in a lot of these cases, the preferred test is actually the VQ scan. It dramatically lowers that specific risk while still giving you the answer you desperately need. Is there a clot or not? Okay, for our final case, we start with something completely different. A couple dealing with infertility. During the physical exam of the male partner, the doctor finds something really specific and very unusual. The vas deferens are absent on both sides. Now, this isn't just some random finding. This is what's called a pathognomonic sign. That's a fancy word for a clue that points to one and only one specific disease.
And that one finding on the exam leads directly to one specific test, the sweat chloride test. If that result comes back greater than 60, well, that's the final piece of the puzzle. It confirms the diagnosis of cystic fibrosis. And what's so incredible here is that this serious genetic condition didn't show up with the classic lung problems. It presented itself as infertility.
Wow. So, after running through all these different mysteries, what have we learned? Let's try to pull it all together into a kind of toolkit for clinical detective work.
Really, it boils down to these core principles. You have to listen to the patient's story. You have to trust your physical exam. You need to know your medical mimics and how to tell them apart. You've got to be able to spot those red flags that signal danger. And finally, when time is critical, you have to act decisively. These aren't just steps. They're the fundamental skills that let a clinician turn a confusing mess of symptoms into a clear diagnosis and a solid plan.
And that kind of leaves us with one final thought, doesn't it? What subtle clues in your own life might be telling a bigger story? Because this power of observation, of recognizing patterns, it isn't just for doctors. It's a tool all of us can use to better understand the world around us, and maybe even the world inside ourselves.